Good morning, and thank you for joining us this morning for Post-Acute Analytics for Hospitals and Accountable Care Organizations. While folks are still joining, we have a few that are still logging on. I'd like to take a moment to share with you to go over just some of the details of today's presentation. Today's audio is offered via either your computer speakers or the dial-in numbers provided. So if you take a look at the side panel, you'll see the additional numbers for call-in if that is preferred. You can also submit questions anytime during the presentation in your right side panel as well. The slides for today are also available in the side panel, and we will also be emailing them to you after the session. And just a note, today's session is being recorded. My name is Maria Arellano. I'm a senior healthcare specialist here at PointRight, and I'll be joined by my colleague today, Karen O'Driscoll, our Vice President of Post-Acute Solutions. So let's get started. Today we hope to bring you some insight into the world of post-acute data and how you may be able to leverage the best information to help you with the development of a data-driven network. We'll also share with you a case study that we believe helps illustrate a great network success story. As we look at the changing landscape of healthcare, we know that change is no stranger to healthcare providers. But the flurry of legislative and regulatory mandates over the last 5 years alone have really altered the way providers interact with each other. On the heels of the Affordable Care Act, the Impact Act, or Protecting Access to Medicare Act, we've seen this continuous stream of proposed rules and final rules that have brought about new challenges. Such as readmission penalties, quality reporting programs, and the new discharge planning regulations that hospitals are faced with. And these are just a few examples of how regulations in one provider setting truly impact the others as well. No longer are providers able to just focus internally. Providers all across the settings, all across the spectrum, are changing their behaviors and paying closer attention to the upstream and the downstream providers. So what is happening elsewhere does matter to you. So it's great that you've joined us here today. And regulatory bodies certainly have not taken their foot off the gas pedal, as they've recently released the new payment models, the PDPM, patient-driven payment model for SNFs, and the PDGM for home health agencies. And they're on their journey to a unified payment model. And once that is fully realized, it is sure to have an impact across the board as well. So if you take a step back and look at all of this, we are really starting to see the CMS Vision coming into focus and how it's going to actually be operationalized. And it's very consistent with the themes of the triple aim, right? The managing costs, the improving population health, and the overall experience of care for Medicare beneficiaries. So let's take a look at the current snapshot of post-acute providers. As you know, these include providers such as inpatient rehab facilities, the long-term acute care hospitals, skilled nursing facilities, affectionately known as SNFs, or home health agencies. And the cost, if you look at it in 2017 alone, the cost for post-hospital care performed in post-acute settings was nearly $6 billion. And 80% of those costs were attributed just to the SNFs and the home health agencies alone. So naturally, these sessions are a key focus for CMS. And for today's session, we're going to be focusing primarily on the SNF data. They're the skilled nursing facility data. And we're going to start here with a quick poll just to get a sense of where everybody's knowledge is in terms of the SNF sector. So if you see the polling, go ahead and make your response. Select the one that best describes your knowledge of the skilled facilities. We'll just give you a few more seconds here. All right. I'm going to go ahead and close the poll now. So it looks like we have a very knowledgeable group today. So that's great. Between 73% highly familiar and 20% moderately, and with about 7% not familiar at all. So hopefully you all come away with something today. Well, let's talk about the post-acute data sources and their pros and cons. There's basically 4 types of data that are available, or they're most widely used for skilled facilities. Self-reported data directly from the facility, claims data from CMS, nursing home compare or 5-star quality ratings data, and minimum data set data also from the facilities. And let's take a quick run through each of these types and the pros and cons. Self-reported data is certainly fairly easy to get. These are the requests that usually come directly from the network or the collaborative or the hospital, asking the skilled facilities to share their quality data. It might be data that comes from their electronic health record, or it may be from a spreadsheet that the administrator maintains on his or her own, just doing their own analysis. But across facilities, it's certainly not standardized. So comparing facilities using different data or where you cannot determine the true source and how it's calculated really isn't fair, to as a judge of their performance. And reporting can be inconsistent. Due to problems with turnover, you may get different data every time, depending on who's doing the calculation. So there really isn't a very valid way to, to validate the accuracy of this self-reported data. The next type is claims data. And, as the name implies, it's based on the data that's included on the claims that were submitted to CMS from the provider directly. It follows the beneficiary, so you can really get a good idea of the different settings where the patient received care, so therefore shows a much broader view of services that were provided to patients. But one, common misconception about the SNF quality measures that are claims-based is that it actually comes from hospital claims. It's not directly from the SNF claims, it's from the hospital. Because if you think about it, in order to calculate measures for rehospitalization, emergency department visits, and successful community discharges, hospital claims are the more accurate source. And clinical data from the patient's SNF stay definitely is used but more in the lines of covariates for the risk adjustment model for these measures. But the actual triggering event is driven by the hospital claim. The drawbacks of claims data, is really that it's only updated twice a year, and for example, the current data available reflects data through the end of 2018. So you see there is a bit of a significant time lag. Some of you that may be involved in bundle payment programs may have access to more recent claims data through your convener, but as a rule, just in general, there's that time delay makes it difficult to use as a performance measure. Claims data also lacks that clinical detail or actionable information to really understand and measure SNF performance. The other drawback is that the data may be a bit misleading because it only includes the Medicare fee-for-service beneficiaries data. So if you have a facility within the network or in your community that has a high number of Medicare Advantage patients versus the traditional Medicare, it may paint an incomplete or misleading picture of the true performance. Now, most folks are familiar with the nursing home compare and the 5-star quality ratings. And this website is it's publicly available. It's web-based, easy to access, and it's pretty comprehensive in its information about SNF performance in the areas of staffing, quality measures, and the 3 years worth of health inspections. So it gives you a lot of historical data. But the age of this data can also be an issue, and it limits the ability to look at real-time performance. For example, the data on the site currently represents a 4-quarter average through March 31st of this year of 2019. We're also hearing some frustrations from some of our colleague hospital discharge planners in the networks we work with or the collaboratives, as it only allows you to compare 3 facilities at a time, and the printing requires an excessive amount of paper and due to these lengthy reports, which makes it really difficult to use for compliance for the discharge planning regulations. The last data source that I'd like to talk about is the minimum data set, or MDS. And for those of you who may not know, it's a federally mandated assessment tool that every facility who receives state or federal funds must complete on every resident. So it's a standardized, fully validated tool, and it has inter-rater reliability. So it's an excellent, that data that supplies is an excellent option for fair comparison across the board. It has a lot of fully relevant clinical and functional patient data. And when you can obtain it directly from the facility, it actually is real time, which is an incredible benefit here. The MDS can be used to derive outcomes, identify risk factors, to use for risk adjustments, and I'm sure that you've all experienced issues with sharing data across settings. So it's certainly, on the con side, sometimes it's difficult to access because of our lack of interoperability. And we certainly are not where we need to be in terms of interoperability. It is getting better, but which makes getting this data directly from the facility certainly a challenge. Unless you're using a third-party data aggregator, getting it into an organized and meaningful report, and then also the database maintenance challenges that can occur, really does require a great deal of resources. So now that we've looked at the data sources, let's take a moment just to kind of go through a three-phased approach that we've identified as successful, and you'll see illustrated in the case study this morning. We begin with phase one. This is where you're really looking at what skilled facilities are in your general service area, in your geographic area. What programs do they offer? What are their capabilities? What types of patients do they accept? So it's really all about that initial research. And when you think about it, you can look at how they're currently performing or what has been their past performance, but what are those key performance indicators that you will use to evaluate SNFs? What are those KPIs that are critical to your shared success? And what data do you need? Where can I get this data, and what is it going to do for us in terms of kind of identifying, evaluating, and ongoing monitoring of the SNFs in our area? The next phase is really about ongoing measurement and monitoring. And so the use of industry standard metrics is critical for ensuring that uniform evaluation across the board. And we have found that they're really an ideal tool for monitoring is a comprehensive scorecard that allows, for easy performance comparison. And it's important to note that providers may change. So we, to really be aware of that. Turnover can be a significant problem in the post-acute industry. And so if leadership changes, you may want to regroup with the new leadership and really reset expectations with the new team. It's not uncommon for performance metrics to fluctuate when there's been a leadership change. Another consideration in this phase is really to think about those ongoing network meetings, either whether they're in person or teleconference or a combination of the two. Those are critical for alignment among all of the providers. And that ongoing communication and team problem solving rather than isolated problem solving really can be beneficial to the overall success of the network. Lastly, one of the key phases that is important is that real-time management of SNF patients while they're still in the skilled facility. This patient-centric case management approach really can only occur with visibility into the SNF data, including those descriptive and predictive analytics that can guide care planning and prioritization of interventions and approaches. Real-time data gives providers that insight into the patients at highest risk for adverse events, those that we know that can lead to poor outcomes or rehospitalization. These risk factors can also be used to help support the SNF discharge planning process, to really help them set their patients and the families up for success once they're back in the community, and hopefully can prevent that rehospitalization. And the only way to achieve this is having the right tools and the right processes. And before I pass it over to Karen to share a case study, let's take another quick poll here. So you should see this coming up here in your panel. And this is really about asking, has your organization developed a network of post-acute providers? Have you done this already? So your options here are no, we haven't done it yet, or yes, we're in those early stages or maybe mid stages, or yes, we have a very well-developed network. So we'll give you a few more minutes here and let everybody have an opportunity to cast their vote. Very good. All right, I'm just going to close the poll here. Great. So it looks like we about 7% have not developed a network yet. 13% are in the early stages of development, and about 80% of you have a well-developed network. So that's great. So I'm going to speak. This next poll is just for those who have that are either in the early stages or have a well-developed network. So for this one, we're going to ask you, what type of data are you currently using to manage your network? All right, looks like we've got some responses coming in. We'll give it a few more seconds here. All right, I'll give you a couple more here. We'll close the poll. All right, so it looks like we have about 54% using claims data, 46% using the nursing home compare 5-star, and this was a select more than one, so that's why we're seeing higher numbers, obviously. Some are 62%. Many of you are using self-reported data from the facilities themselves, and about 38%, excuse me, using MDS data from the partner SNF providers. Very good, very good. Thank you for sharing that. So with that, I'll go ahead and turn it over to Karen.
Great, thanks, Maria. So if you could just switch to the next slide, that would be great. But I really want to thank you for providing such a great, informative presentation, for helping us understand the different types of claim or the different types of data that's available and the pros and cons. As I look at this in the self-reported, a lot of people are using self-reported data by the SNFs, and hoping that they understand the pros and cons of that, which is awesome. But also helping us to understand, excuse me, where the audience is at. So what I'd like to do now is really share a success story of a PointRight ACO client that's really finding some significant value by incorporating data insights into the management of their post-acute network. So this ACO consists of a large health system made up of 2 hospitals located in southern New Jersey. Their hospital service area spans 4 counties. They are responsible for 85,000 lives, and 24,000 of those lives are actually linked to Medicare. There are 180 primary care physicians within their ACO that make up or represent 45 practices, and their population is quite diverse. Next slide. So the organization began their value-based journey back in 2015 and really used a multi-phased approach as they looked to measure, monitor, and manage their post-acute network. As they evaluated the SNF market, they identified several challenges. And as you look at these challenges, you're probably thinking, yeah, I agree with this and agree that it's common. So the first one was lack of collaboration with the SNFs, both at the hospital level, but also amongst the SNFs. And like I said, when we work and start to bring on ACOs and health systems, this is not an uncommon theme. Although the hospital service area was only in 4 counties, the beneficiaries were actually being discharged to 160 skilled nursing facilities, and it spanned 8 counties. So it really made it hard for the ACO to not only know where their members were, which I'm sure people on the call are agreeing with, but it also made it hard for them to control quality and cost. And that was, the cost factor was really confirmed because, as you can see here, the average cost per beneficiary was 25% higher than the national fee-for-service rate and 36% higher than other MSSP ACOs nationally. Next slide. So the first phase they determined was to really establish relationships with those skilled nursing facilities. So they brought the skilled nursing facilities together to discuss the program and determine the level of interest. And as you can imagine, for the hospital providers that are on the call, or the ACO providers, the nursing facilities were eager to establish that relationship. From there, the system looked at developing a number of measures that the skilled nursing facilities would be evaluated on. And they decided to utilize PointRight scorecard to grade the skilled nursing facilities on critical benchmarks such as overall risk-adjusted rehospitalization rate. But they also were interested in risk-adjusted rehospitalization rates for specific clinical cohorts such as CHF, COPD, pneumonia, a lot of the common ones that are associated with the hospital readmission penalty. They also wanted to look at quality measures and care processes and determine how those skilled nursing facilities were comparing to each other in that area. And because they have and are part of the 3-day SNF waiver program, they still needed to look at the star ratings, even though they realized that there were pros and cons to the star ratings, they still needed to pay attention to that. By utilizing the scorecard, it eliminated the need, like we had mentioned earlier, the need for the skilled nursing facilities to self-report. It took the burden away from the health system needing to develop the analytics on their own and hire, an analytic team. And it standardized the process across the board, which was key for them. They were quickly able to identify who were, and they continue to identify who are those high-performing skilled nursing facilities within their geographic area. And the analytics has provided a framework for them to set goals and regularly monitor the progress of those skilled nursing facilities and the network. The results are shared on a monthly basis with the skilled nursing facilities, and it's really created a competitive spirit amongst the skilled nursing facilities. The data is totally transparent, and the nursing facilities can see how they compare to each other. And it's created a lot of not only competitive spirit, but a lot of sharing of best practices across the network. And then from there, the information is shared with the patients and the family. They created a list of preferred providers, and they are sharing it with patients and family so that they can make an educated decision based on quality and not just an emotional decision. And then the network is reset or updated on a quarterly basis. Next slide. And as you will see here, developing and nurturing those relationships with the skilled nursing facilities has shown positive results for the ACO. So when they began their journey in first quarter, their annual spend per beneficiary was $1,055. And by the end of the first quarter, it had decreased to $918, which showed a 13% decrease in SNF cost. And there was also a 14% decrease in SNF days. They were identifying who were the high-performing skilled nursing facilities or the right skilled nursing facility that could provide the best outcome for the patients and their specific needs and decrease cost in days. And this resulted in an overall $6.6 million reduction in medical costs. Next slide. Then they took it to phase 2, and that really consisted of expanding the relationships, but taking the relationship to a deeper level. The health system identified 8 skilled nursing facilities in that network that were not necessarily the best performers, but they were important to have the relationship with those skilled nursing facilities due to geography and access for care for the skilled nursing facilities. And they implemented a SNFist APRN program. So they hired APRNs and SNFists, and they placed those teams into the centers to follow their members, be able to identify high-risk patients, and then be able to take preventive action. And those APRNs and SNFists also attend the care transition meetings on a regular basis. Next slide. And as you can see here, phase 2 results, they saw an even greater success by decreasing the annual per beneficiary spend by 44% from Q1 of, when they first started their journey. So their annual per beneficiary spend decreased to $585, which is below not only the national average for MSSPs, but also for fee-for-service as well. The key thing for the ACO is that it actually resulted in a $3.5 million earned share savings. So I think you'll agree that not only having the right data, but also incorporating data insights into the management of your post-acute network can help you be successful as well. And the skilled nursing facilities have seen significant improvement as well. So it's not only benefited the ACO, the health system, the skilled nursing facilities, but there's been an improvement in quality outcomes for the patients. Next slide. So the health system continues to use data to manage and monitor their network and to reset the network as needed. The analytics, like I had mentioned, not only help the health system and the ACO to improve overall, but the SNFs have seen improvement in their quality outcomes. And really the next step for the health system is to transition to phase 3, which is looking at implementing RADAR, which is our patient-centric risk mitigation solution, and it helps manage clinical and financial risk through predictive analytics. It allows the health system to have real-time insight into what's going on with the patient, not only with regards to level of impairment for ADLs, mood, behavior, and pain, but it also predicts risk for falls, pressure ulcers, rehospitalization, and mortality. And Maria, I think as you had mentioned earlier, RADAR can help with managing length of stay by identifying the level of discharge complexity for those patients. So we're very excited to move to the next steps with our client in New Jersey as they venture on into phase 3. Those solutions that you see here that are highlighted were discussed in the case study. So we've talked a lot about RADAR. That is our risk mitigation tool. Like I had mentioned, it used descriptive and predictive analytics at the patient level, so you can really see what's going on at the patient level. It helps as far as discharge complexity and managing length of stay and mitigating adverse events for that patient. The first solution that we talked about is the PointRight scorecard. This is a comprehensive solution that really helps provide directional insight into SNF performance within a specific geographic region. So one of the key things with the scorecard is that you're able to go in and create comparison groups based on a specific geographic area. You can drill down to a zip code, you can look at county, you can look at a hospital service region or a hospital referral region, or really drill down and look at a comparison group, however you want to slice it and dice it. And the important thing here, and the reason that we've we've created the scorecard at that level, is because we know that healthcare is local. So it's nice to be able to go into CMS and compare nursing facilities, but it only looks and compares nursing facilities down to the state level. Whereas with a SNF scorecard, you're able to get at a local level and create your own comparison groups. And then Pro 30 rehospitalization. This is the only all-cause risk-adjusted rehospitalization measure available. We're very proud to mention that it's endorsed not only by the NQF, the National Quality Forum, but it's also been endorsed by ACA, the American Healthcare Association, and it's recognized as a standard in the industry. Next slide. So as follow-up to today's webinar, we'll be sending out the slide deck, but we're also going to be forwarding you a copy of our white paper on post-acute analytics, a strategic framework for hospitals and ACOs. So please be on the lookout for that in your email. That will be coming to your email after the first of the year. Next slide. And to learn more information about PointRight and additional products and solutions that are available for hospitals and ACOs, to look at performance management, to look at network management, and to look at patient management, please visit our website at pointright.com. And if you have any further, next slide, if you have any further questions or would like to contact Maria or myself, our contact information is available here. And what I'd like to do now is open up the panel and see if there's any questions. Maria, I'm not sure, were you able to look to see if there are any questions from our attendees?
Yes, I've got the question panel open. I do not see anything yet. So go ahead. If you look to the right side of your screen, you'll see a question drop down. You can go ahead and ask your questions there if you have any.
Either our audience is shy. Great. Well, if anybody does have questions once we end this webinar, again, our contact information is here. It will be included in the slides, and please feel free to reach out to us individually, and we can answer any further questions that you might have. If you're interested in, sitting down one-on-one and having a demo provided to you, certainly we can do that as well. And if there are no further questions, we just want to wish everybody a very happy and healthy holiday, and look forward to a prosperous new year.
Thank you.
Thank you, Maria.